Good afternoon. I'd like to welcome you to the Medical Center Hour for today. I'm Marcia Day-Childress from the Center for Biomedical Ethics and Humanities here in the medical school, and we're delighted to bring you these Medical Center Hour forums every Wednesday through the academic year. Our program today is called Better Brains, Ethics of Neuroenhancement. In recent years, the Medical Center Hour has taken up controversial questions about how medicine can not only prevent or cure dread disease and repair broken bodies, but also how it can sometimes quite dramatically improve upon the normal appearance or performance of human form and function. Today we inquire into a 21st century frontier, the question of engineering better brains for ourselves, the question of neuroenhancement. By neuroenhancement, we mean the use of medical, especially psychopharmacological means for enhancing healthy persons' moods and/or cognitive functions. At present, both within and beyond medicine, the debate over neuroenhancement remains fairly hypothetical, given that proof is lacking for both safety and effectiveness of the various substances employed in pursuit of improving the human brain. But neuroenhancement as a reality looms on the near horizon. Indeed, some may argue it's already here. Our session today, which is the Hollingsworth Lecture in Ethics at the University's Institute for Practical Ethics and Public Life, focuses on the ethics of neuroenhancement. We welcome as our Hollingsworth lecturer Dr. Bettina Schöne-Seifert, a physician, philosopher whose work grapples with, among other things, bioethical, critical questions about our making better brains for ourselves. Leaving aside questions about neuroenhancement's efficacy and sufficient safety, could we expect such improvements to jeopardize or to contribute to human flourishing? Does neuroenhancement in any way threaten a user's virtue or his or her true nature? Or does it somehow endanger his or her authenticity? How might neuroenhancement affect our conception and sense of the good life? And how might we responsibly proceed to explore possibilities of better brains? Under what conditions? And for whom? Dr. Schöne-Seifert is visiting us from the University of Münster in Germany, where she is university professor and chair for medical ethics at the Institute for Ethics, History, and Theory of Medicine. She also sits on the National German Ethics Council. As part of his response, Dr. Daniel Larriviere of UVA's Department of Neurology and the School of Law will discuss the American Academy of Neurology's position to be made public in a statement issued later this afternoon. So that actually will affect what he's able or not able to talk about, as it turns out. But that statement has to do with the ethical permissibility of neuroenhancement. So there's been a nice coincidence of timing here. Too bad there wasn't another 4 hours forward. You'll find brief biographical sketches of both of our speakers in your handout, and there's also a nice list of resources on the topic of neuroenhancement for your further neuroenhancement. We'd like to thank the Institute for Practical Ethics and Public Life for their generous support for this program. And also in your handout is an announcement of another program at which Dr. Schöne-Seifert will be speaking tomorrow afternoon at 5 o'clock on is rationing healthcare unethical. This will be at 5 o'clock in 107 Clark Hall, also sponsored by the Institute. Tina, welcome.
Thank you, Marcia, for this kind introduction. Actually, tell me, since the delay is my fault causing these technical problems, does that cut my 35 minutes time? Not really? All right. You're fast. I tried. So I'm very pleased to be here, dear colleagues, dear Marcia. And I will just make sure that you do not expect me to give ready answers to these difficult and complex problems. We are all aware that this is a topic for debates continuously to stay alive with us. But at least let me give you some ideas on what I think we should further pursue, very selectively though. as philosophy always does, we have to invest a couple of minutes on terminology, a little bit in repetition of what Marsha already presupposed or just mentioned en passant, but we should really make sure that we talk about the same things. Enhancement is, as you can tell, not a terminology confined to the brain. So let's first talk about enhancement in biomedical contexts. Enhancing means to improve, to make better, to strengthen, to optimize even if that's possible, to make better. And one thing that is quite unanimous among people using this terminology is that enhancement is meant to be an opposition word to treatment. So this, of course, doesn't make it easy to identify enhancements strictly, since, as you all know, health is a loose concept, and treatment and enhancement, inheriting the looseness of their underlying concepts of health and disease, inherit the corresponding vagueness. So whatever you do in healthy being then is enhancement. Whatever you do in sick people is treatment, be it by the very same means. Now, rather than quarreling on the philosophical and medical theoretical issues of pinning down the exact borderline separating treatment from enhancement, separating health from disease, we should, I suggest, leave that muddy gray area of the in-between and concentrate for the argument's sake and for the moment on what you might call genuine enhancement. So if you use a happy pill or a smart drug on somebody, like everybody of us I hope, who is beyond a suspicion of being depressed or having a pathological cognitive deficit, you will then speak of genuine enhancement, leaving the problem of the exact bordering and the gray area at side for the moment. Now, talking about genuine enhancement invites for another differentiation in common expert terminology, and that is for differentiation between compensatory enhancement and radical enhancement. Now, again, taking, as I suggested to do, only healthy people as the addressees of potential enhancement, somebody who would be, in terms of happiness and sadness, more on the lower side, could say, I compensate by taking a happy pill just to raise up in the spectrum of what's daily diversity among us. Somebody, in contrast, who uses an enhancer to leave what is considered the normal spectrum of human possibilities and capabilities would perform radical enhancement, according to that terminology. For example, getting a sense for ultrasound, an extra seventh sense, being like a bat, which is a famous philosophical question, would it be like feeling a bat? That would be radical enhancement, transgressing human possibilities. So now, for the time being, the short time we have, let's stick to non-radical enhancement, but rather to enhancement that is really within what we already know to be normal human diversity and possibilities. The next thing one has to debate is, does enhancement of this defined category ought or ought not include prevention? And here you find different use of speech among experts. Some would say, yes, changing our immune system to the better by vaccination is doing something in the healthy, so it fits this concept of enhancement. We should include prevention. Others, including myself, would say no, let's keep prevention out, for the very reason that the goal of both treatment and prevention is fighting against disease, be it ex ante or when you have it, or even ex post to alleviate symptoms. But the very goal of prevention and treatment is the very same of fighting against disease, whereas the goal of enhancement is not connected to any idea of disease, but doing something for the betterment, so-called betterment of the healthy. So I suggest in this controversial question of looseness, narrowness, or wideness of the concept to exclude prevention. And then, in parallel to the goal question, you have a question of the means. Some people do include, under the concept of compensatory enhancement in the healthy, things like drinking coffee, coaching a person in psychosocial terms, playing Sudoku even, the conventional means that we use to enhance ourselves. Including, as people like Dan Brock or Julian Savulescu or Daniels even suggest to do, including an ordinary coffee drinking under enhancement, already makes the term a little more sympathetic to everybody. This is the very reason that critiques would say, gee, what they do is semantic prejudice. They already make the term to look nice. They include something we clearly don't dislike in order to open the door for affirmation towards the idea of enhancement. Therefore, exactly for this reason, I suggest to exclude common procedures out of the concept and use it narrowly, both mean-specific, meaning we only use biomedical technology, pills, chips, interfaces that were originally, by the way, developed until now, most of the time, to be treatment means and not enhancers. And luckily or unfortunately, they turned out to have potential for enhancement too. The motivation to choose the narrow concept, only biomedical means in order to improve the healthy beyond questions of pathology, is that we should use this concept to give a signal. And the signal is, listen guys, listen folks, this is new terrain for new ethical questions. This is why we use the narrow concept. It might very well turn out that there is a moral continuity between drinking coffee and taking a smart pill. This is left open for the moment, but we shouldn't prejudice conceptually. And to be on the safe side, I suggest to use the narrow concept and exclude all the other things. What happened here? So now, let me briefly map ethical concerns. And I can already tell you in advance there are so many of them that we can only pick some of them and selectively throw some light on them. So usually people come up with a bunch of categorical objections. Categorical meaning in this context that you don't even look on the consequences of a single or an aggregate use of enhancers, but you look at the thing per se. And there, a bunch of people would say, gee, this is really against nature or even against human nature. So therefore, we shouldn't consider this to be an acceptable practice, and we should try to outlaw it, or at least to educate kids against using it. This can't be for the good of humanity. But on second thought, this is at least a very problematic argument, given the fact that the naturalness, artificiality distinction doesn't have any normative relevance in many other contexts. I mean, if you look at the goals of medicine, it's all fighting against nature's dark sides. If you look at cultivating nature for the good, ecologically good, what we do is really changing nature to fit human needs and interests and animal needs and plant interests, hopefully, better than it does by itself. So really, being against human nature per se is not a convincing argument, and it's quite ad hoc if you use it in this context and not in others. This, of course, does not mean that there isn't something to a very heuristic argument, saying, listen, nature very often knows better than we think we know. So be careful, do things step by step. Don't really intervene in depth before you know what you do. But that's a different argument. It's a very pragmatic one, and it's not the categorical objection to be against human nature. Another objection of this kind is that People tend to say, in particular with regard to neuroenhancement, that we now confirm ourselves to smart pills, happy drugs, just being the paradigm ideas, that really using them is intervening on the wrong level of intervention. And they would contrast these things to, let's say, psychotherapy on a couch, really working hard on introspection and changing yourself by really arduous efforts. And people would say, just taking the shortcut by throwing a pill can't possibly be the same as the long and difficult way of doing it on the couch. Now, this is really putting question and answers upside down, because in our hypothetical looking at these ethical arguments, we should presuppose that really those pills do work in the way people use them for. I mean, if it turned out that really the happy pill is only taking you to a kick for the last 3 hours, and then afterwards you get depressed again, and it doesn't really help to make you feel better on long term, functional equivalence wouldn't be given, and therefore people would not replace psychotherapy by pills, I suggest. They would maybe combine the two, and that might be a question to the expert then afterwards. But the story gets only interesting if we presuppose some degree of functional equivalence. So in part that's an empirical question, of course, whether it can be proven true. I suspect that a categorical assumption of functional inequivalence of psychotherapy and the pill is really based on a functional dualism of some kind that we really don't presuppose and take for granted in philosophy of mind in other contexts. It does presuppose that reasoning, doing something consciously, deciding yourself to do something, is a totally different category of just influencing neurobiology. But if you turn into substantive monism and acknowledge that even accepting reasons does do something in your neurobiology and vice versa, this separation doesn't lead anymore as neatly as critiques wanted to claims of the wrong level of intervening. So let's now look to the other arguments that don't come categorically, but look at questionable or allegedly questionable consequences of using neuroenhancement. And let me stress again what Marcia already mentioned, so as not to mislead you. I'm talking about all these issues purely hypothetical in the moment. Suppose science will really make it true that we do come up with smart pills and happy pills that do the job that are suspected to do, doing it safely and potently. What do we do in ethical terms? And the empirical factual questions will be handled by my successor later on. So now look at the questionable consequences and so on. Here again, people do normally make a difference between those consequences that happen on the individual level, the key word here being the flourishing life, the impact of taking smart and happy pills on people's individual happiness and good life and so on, and the social level. But it is very obvious on second look, these things don't fall apart as neatly as paper wants it to, because of course individuals live in a society and things are really intertwined. So just let's look at the whole bunch of arguments. There are of course safety issues, risks and potency that have to be dealt with in individual settings. Then for the individual, a big question could be the pressure to use happy pills, or to compete with others, to be efficient in cognitive terms. There is the idea of a loss of virtue that I come back very soon, and the argument from the endangered authenticity, which comes as a very suggestive argument, really, when people use it. On the social level, you have at least the concerns of getting led into an even more competitive society than we have it now, into questions of fairness and access to enhancers who don't promise to be that cheap. The so-called argument from escapism that I will come to in substance in a moment, meaning that neuroenhancement might provide us possibilities to escape the darker sides of our social problems and just make ourselves happy without really fixing at the right level, adapting ourselves rather than changing society, escaping the problems. And the issue of conformism, that we all might tend to get as happy and as smart as we can and lose a lot of human diversity that is really enriching social life and individual life. Now, I decided to pick 3 issues that will turn up to touch various of these points on the list and therefore prove the pieces that really things are intertwined. So now, one of the big questions really is, are we up, in case we get these things and use them aggregately, more and more people using it, are we up on a track into an even braver new elbow society? This is a concern that should be taken serious. One reason being the fact that, as we will hear later, I expect people tend to use these pills to an increasing degree, to say the least, without really knowing about issues of safety and potency. This already shows that there is to a high degree, a competitive motivation behind using this stuff, because otherwise we would be careful with these kinds of self-experimentation and rather let science look at whether it really is good or not. The fact that people use it is an indicator of an induced motivation that comes from outside rather than from making your life happier. The big concern that makes up for the next step is really that it can be foreseen that quite a number of people, maybe the majority, would really not like to take this stuff and would prefer, for one reason or the other, to stay natural. And of course, it ought to be their right to stay that way. So how can we make sure that there isn't latent pressure that's really pushing people into using these devices, although they really dislike the very idea? Now, one could of course say there has always been the problem of people who feel forced and indeed are to a certain extent to adapt to new innovations. People who wouldn't use cars or trains or planes, people who would refuse to use cellular phones, can't compete in many of our working areas. So it's a luxury to say I stay Amish and I just don't take part in that life. But then the question is, of course, does it make a difference whether it's cell phones or smart pills that you adopt to or not adopt to? Some people would say, and my sympathy is on their side, that really, at least, this is a matter of psychology. It does feel different whether you have to intervene in your brain and do it because of outer pressure and not because of conviction that this is something you would like to try. So there is a difference, at least a felt difference, between using these pills and adapting to other technology. Could it be, that's the next problem in this field, could it be that the very availability of pills that help keeping us alive, awake, is not the right word, keeping us awake although we don't sleep very much, of having pills that increase our attentiveness and alertness and memory, wouldn't that, in the end, just lead to another increase in the workload? Wouldn't it just be a spiral in competitiveness that everybody is taking part in, so that employers really expect people to take the stuff to do more work, and if not, they get fired? So does it really do anything good? Well, the other side of the coin is that very obviously these drugs, these devices, needn't be used only for competitive reasons. If you look at the history of art production, you bet that many of the best pieces of literature and music wouldn't have been produced without wine, coffee, nicotine, and many, many other stories. We are now talking about pills that might be ideally only burdened by very little side effects in comparison to the heavy problems that these other drugs, enhancers, do have. So isn't it really a little one-sided, one should say, to stress the negative competitive potential of these new drugs and to look only at the good sides of the others? Couldn't we also try to use enhancers for the better of society and for the better of individuals who could decrease their workload and learn 4 languages instead of 1 without big effort, using that for social goals that might be beyond their egoistic interests? Couldn't it really help to make people more sympathetic, to be more open-minded, to be more social, and commonly build for a better society? What really is the relevant difference between these pills that the future might bring us and all these incomplete and rather insufficient devices that have been used through humanity's existence? It has always been part of humanity to improve itself by whatever device is available. Something that's close to the Brave New World idea is the argument of quick fix. Doesn't it really disturb many aspects of life individually and socially that are dear to us? One way to pronounce that is to use the so-called Calvinistic arguments that have been called Calvinistic in that debate, claiming that really part of the story is the way. It's not only the result, the achievement, but the frustrating way of exercising piano, of trying to write the novel again and again and over and over again. And that really it's not the results per se, but the whole procedure that's part of the story. Well, this is certainly true in sports, I'd say. There, we like to look at our athletes, not because it matters to us whether absolutely the height they jump at or the speed they sprint at matters, but because we sympathize with the idea of hard training and really doing something for it and so on. So we are not interested in the absolute achievements. But that might be different in other contexts. I mean, just being able to speak 3 languages fluently without much effort is per se a wonderful thing, because it would make it much easier to talk to people in other countries and even use that to their betterment. So globalization, inviting for communication, would really profit from that. And there are many, many, many other arguments and examples that can be held against that. Another aspect of this quick fix concern is that people might lose what psychologists or philosophers might like to call secondary virtues. That is, virtues that do serve all kinds of other purposes, like frustration tolerance, self-discipline, the ability to live with mistakes and non-achievements. The idea is that when the very availability of quick pills that make us able to do the work without sleeping, to concentrate better, this enables us in the regard of living with hard work and failure and self-discipline. Again, this I think is a very pragmatic and very important argument, but we don't know yet. I mean, we don't know whether the availability of enhancers at some points will really lead to disturbing that kind of virtue that we really do need in life. then here again there's this argument from escapism or from quietism, the argument that really it's the wrong point to change. Adapting people by making them content even with dissatisfying conditions shouldn't be the way we handle social problems. It should be the other way around, those critiques say. Let's change society to the better and not make people adaptable to the misery we don't change. Related to this, there is the concern that really by offering pills to people and to ourselves, we might get blind and deaf and not realize how many suffering there is and how many need for reform and for improving society and really working hard on that. Again, this is an open question, and as in so many other regards in human life, it's probably not a yes or no answer that has to be given to these concerns, but a cautious approach, being aware of the very fact that you can use and abuse the very same means for various goals. Now, coming to my last selected concern, that's the suggestion that people who use smart pills, not so much cognitive enhancers, but really pills that change their mood, their outlook into the world, their color of experience, so to say, that those people in danger of maybe even lose authenticity. Now, the big problem with authenticity coming along so philosophically loaded, the big thing is that it's a very loose concept, used for a variety of things that are somehow intuitively interrelatable, but not really analyzed neatly. So some philosophers have used the notion of authenticity to depict a certain relation we all have to ourselves, an opaque notion of self-relation that's not really shared with others. Others have used it to name a character ideal of being a non-conformist person, and so on and so on. You can really make up for a whole family of somehow related notions of authenticity. Here are three that are really frequently used in the concept. But before coming to that, there's something messed up. Let me stress my impression that I could prove by names and print that really authenticity is very often coming along as a mislabeled critique. In reality, meaning expressing arguments from nature, from nature's normative worth, or from virtue. Some people would say taking pills of that kind is inauthentic, and they mean it's because it's changing your nature in a way it ought not to. As I said, one should discuss these naturalness, the argument from being untouched and staying in a way that nature wanted us to, under the right label. One should discuss it as a naturality argument and not as an authenticity argument. And the very same can be proven for virtue arguments. But if we concentrate on more genuine understandings of authenticity, here are three. One is authenticity as a metaphysical concept. It's nice for philosophers to deal with that, but I'm not sure you really get something out of that for our debate in the end. It's the notion of there being something that is either dynamic or stable that makes up for your real self, and people would fall apart in criticizing or in being in favor of changing or shaping this notion of the self. Some people say there is a given, a static notion of authenticity, and fiddling around with this via pills or chips or what have you is really not the right story. Others would say this is a malleable thing, this inner self, and we have always noticed that ourselves and our fellow beings much of the energy in shaping the cells according to their notions of what's wishful. So really, I don't think that the idea of authenticity as a metaphysical concept could really help a lot, but here are two other understandings that might do better. One is the notion of authenticity as coherency of one's values. Obviously, this is nothing that ethics can require from people, but it's an ideal of a good life that people should not act and behave in a way that's really against their deeper preferences and value commitments. And the idea, of course, is that it's a good thing to have value commitments too. Now, here we get into well-known trouble, well-known in philosophy of mind. What does it mean to interfere with coherence? I mean, take some person that has always been shy, not pathologically, but just shy, and suffered from that in a way. She has led all of her life according to this given shyness, so she would turn down things that she intellectually liked to do, because she would know that once she had to stand there in front of an audience, she would fall into shyness and really not do a good job and feel ashamed afterwards, and so on and so on. So she has really led all of her life and set her values, her preferences, if you like, according to this given fact of being shy. What happens if there is a pill against shyness? That's helpful, and she takes it. Does it really disturb the coherence of her values, or doesn't it rather stress the right one value that was always at top of the given, that is the desire to overcome shyness? So really, that is a very difficult and complex notion. And the very same is being true with the idea of authenticity being in charge of what one does. That's, I think, a notion that can be identified to lie behind authenticity talk in this context quite often. We all share the idea of wanting to be responsible for what we do. It ought not be the pill in the exam, but it ought be ourselves who do the good exam. It ought not be a pill that makes us socializable and friendly and loved by our friends, but we want to be it ourselves. And so this really is something that one should look at deeper, I think, and this is my last point, really. Something happened here, I don't know. No, wait a second. Okay, I've lost that. I'm sorry, this is the technical problem that we had. I changed from one program to the next and something happened and got lost. So let me do it without a slide. The idea really is that there are at least two aspects touched by the notion of authenticity as being in charge. One is that we do not wish ourselves and our kids who might use those pills to feel self-alienated. That's a very important thing. We know from experience of psychologists treating children with ADS that it's very important to give them the idea and educate them in a way that they feel in control of taking these pills and of not having the feeling that there is something happening with them that really is beyond their control. So we would never have the idea of self-alienation when drinking coffee or when using a lens for doing better in mechanics and improving sight beyond what is normal. We would never have the idea of being self-alienated or of witnessing self-alienation. But we don't really know yet what happens when using such pills. The other aspect really is that we should never, for a flourishing life, we should never get the notion of cheating in using these things. It cannot contribute to a flourishing life if we take pills of that sort undercover, don't tell it other people, use it by explicitly or implicitly violating regulations or rules that do exist or that are only allegedly existing. And now comes an interesting point. The idea of cheating and being self-alienated is one that as from third-person perspective as an observer. And the two, again, interrelate. If you know, if you take a pill, improve yourself in terms of mood, feel better, feel nicer, feel more empathy, and your partner takes you to be changed and not to be the real person and not the one you used to be yesterday, the Jekyll and Hyde suspicion, then this cannot contribute to a flourishing life. You will feel ashamed. And you will certainly not use this as feeling in charge. So there we have the problem that the normative positions one takes in society towards using these pills will influence the look at somebody who takes it, and then will in turn influence the feeling of the user. So there is a whole interrelated problem of moral and psychological answers to these new opportunities that are pretty much in a dark box so far. And I think this will be one of the big problems. It might be interesting to go deeper into the issues of self-alienation and cheating in the context of Viagra, sexual enhancers. There we have a lot of data, when it's used officially for pathological reasons. We don't have these data for people who just use it openly as an enhancer, whether women of Viagra-taking men appreciate it or not appreciate it, or even don't know. There are some evidence that men would tell. So my tentative conclusions, there are no real genuine objections right from the beginning against using these things, because there's so many continuities with means we do like and do use already, that there can't be hard reasons to prohibit the whole thing. But we do need open debate, and we do need, that's a very important thing, independent research on these things. Research that's done under the label of enhancement and not medicalized and not pursued by pharmaceutical industry, who has a big interest in getting these things marketed. We should really educate ourselves and people about the dangers, about the medical pros and cons, and also about the complicated ethical implications. And we do need, in any case, we do need a very careful psychological monitoring, proving whether these pills turn life to the better or to the worse. And in part, we can't yet know. So okay, that's it.
When you get in set up, I'll go ahead and start. We're running a little short on time. My name is Larriviere, as Marcia told you. I'm in the Department of Neurology here, and I've been asked to talk about some of the work that I've been doing with the American Academy of Neurology and the Ethics, Law, and Humanities Committee, which is a committee that I chair. We've been working on a neuroenhancement statement for the last couple of years, and as Marcia mentioned, it's going to come out today at 4 o'clock, and this is the title, and I'll give you the website where you can get it this afternoon when it comes out. I'm sorry that I don't have it. I'm sorry it's not already published, and I've been told that I can't talk about the content directly for fear of violating the embargo. So I'm going to just give you some of the issues that we try to address. And because I'm the chair of an ethics committee, I always start with a disclosure statement. I receive educational grants from Larriviere and from the American Academy of Advancement of Science. And if you perceive any bias in my talk that you think might be influenced by these entities, please let me know. I'm always interested to hear that. Just a quick little blurb about the American Academy of Neurology. It's the largest neurological organization in the country. We represent about 21,000 neuroscientists and neurologists in the United States. The committee that I sit on is the Ethics, Law, and Humanities Committee, and our committee is to serve our members by fostering professionals in ethical behavior, compliance with relevant laws, and to encourage an appreciation of the humanities in the practice of medicine. And our specific purpose is to develop statements to provide guidance for our members, both in the ethical and legal worlds, and some of the issues that they face every day. We also advise our board of directors about some of the policies that the Academy comes up with. In 2007, I brought this issue to our committee because I've been doing a lot of reading in the area, and it was something that was interesting to me, and I thought it might be interesting for the committee to address, and that is the issue of neuroenhancement, which we've been hearing about. And this is how we define it. And I can read it to you, that in the last decade, persons with no diagnosed disease or disorder have been increasingly seeking and utilizing, for the ostensible purpose of enhancing their memory or cognitive skills, prescription drugs that were originally developed to improve executive function or memory in persons diagnosed with disorders such as attention deficit hyperactivity disorder and Alzheimer's disease. We made a normative declaration that that's a neuroenhancement. At the time, when I brought this to the committee, a lot had been written about this subject, both in the lay press and in bioethics journals. The thing that made me want to address it a little bit more closely was that none of these provided a lot of clinical guidance for physicians who might be approached by patients who request these medications. And we thought, based on some indirect evidence and some anecdotal evidence, that this might be happening more. So our purpose in providing the guidance statement was to give clinicians just practical guidance about how to think about this issue when they're faced with this in clinical practice. And the questions we tried to answer were several. These are some of the ones that we thought I think were really important. And whether providing a prescription for a patient who has no disease or illness is ethically obligatory, prohibited, or permissible. Whether it's legally obligatory, prohibited, or permissible. And whether or not neurologists, since that's what we are, and that's what I do, how should we respond, or can we respond to patients who request this medication? And should these people be considered patients? That was actually quite a divisive issue on our committee over the 2 years we debated this. And finally, from a pure pragmatic clinical standpoint, whether or not there was enough evidence, both in terms of efficacy, long-term effects, etc., to justify the use of these medications in normal people. I can't tell you what we answered, but I can tell you how we developed it. We developed a series of drafts from the fall of 2007 to the spring of 2009. We had 5 ethics committee meetings, and in each meeting we went over the draft and we revised it. When we got to our penultimate version, we gave it to the board of directors and committee chairs for academy policy. So everybody in the academy had an opportunity to take a shot at it, a little pinata. We gave it to our membership, and not the entire policy. We gave a series of points that we distilled the policy into to the members of our annual meeting in Seattle. And based on that feedback, we revised the policy once again. We submitted that for publication to the journal Neurology in May. It was approved for publication and then approved by the board of directors as official academy policy, and it will be available today at that website at 4 o'clock. Just some general thoughts, though, about what I see as the issues here, and just some things that I think about when I think about this issue. I don't think enhancement per se is controversial. Dr. Schöne-Seifert elegantly laid out some of the issues, and I think at the end of the day, we enhance ourselves in lots of different ways, some of which are older, some of which are newer, but at the end of the day, trying to make ourselves better isn't a bad thing. And I don't think enhancement is cheating. A lot of people assume, or the way the debate is framed, is if you take a pill, you're going to be smarter. And that's not how these work. At best, these pills create a situation in your brain that allows you to do something more efficiently, but you still have to do it. You still have to make some kind of effort to achieve what it is you want to achieve. So I don't consider it to be cheating. It's just making it a little bit more efficient. I think some of the things that are going to be more troubling, assuming for the moment that physicians can prescribe this, there's no ethical or legal limitation for us to do this. One of the chief problems is going to be patient expectations. If I take a pill to lower my cholesterol, a pill to make my blood sugar better, I can get a pill to make me smarter and I'll be fine. And I think that's something that we address this in the paper, and it's something that I think that's going to be important for physicians to address going forward. A big issue is diversion in some populations. We know that at the middle school, high school, and early college level, there's a big issue with this. A lot of the juvenile medicine physicians tell me that it's a big issue, and I teach at the law school, and I teach medical students, and I teach undergraduates, and I've sort of queried them from time to time about this issue. And everybody knows where to get the pill when it comes to exam time. They know who has them, they know who has extras. They know how much they cost. I think when we developed our policy, we stayed away from juvenile and children, and we addressed only those issues of adult patients for this reason. We may take a whack at trying to develop a policy for other populations, but I don't know if we're up to it or not. A big issue is the efficacy of the medications, both the ones that are in existence now and the ones that are in the pipeline to be developed. We don't really know what these medicines do to normal people. There's some studies that have been done, they're very small, and they involve mostly paper pencil testing. Some of the studies, a couple small studies, involve tasks. But it's not clear to me that these medicines are going to do what everybody thinks they're going to do. There appears to be a U-shaped curve in the response to these medicines, meaning people who are already functionally not doing so well benefit much better than the people who are already high functioning. And if that's the case, I think a lot of the issues with competition and with overuse of people who are already on the high end of the curve, and therefore some of the justice issues might be done away with. I don't know that, but that's just sort of the gestalt that I get from reading some of the studies. And we don't know about the short-term and long-term side effects, both at the clinical level and at the cellular level. We just don't know what this does to people in the long term. And we need to understand these things before we start passing these medications out, I think. And then, just as an aside, I think there's going to be a high potential for placebo effect with these medications. So even if I give it to a patient who's normal, if they perceive it to be helping them, then maybe it is. And then there's going to be an issue about getting them off the medication if I think that this is having some deleterious effect on them. And so we talk about this in the paper a little bit, but I think it's something that every physician who gives patients medications has to think about, especially with these. We don't know about their potential for abuse, although we don't think of these medications typically as being abused like cocaine or some of the other street drugs. People do use these in ways that they weren't intended to be used, meaning they crush it up and they inject it or snort it. But if it's used as it's prescribed, we think the likelihood of potential abuse is pretty low. That's all I have time for. I'm happy to take questions from here on out. Thank you.
Thank you very much. We have time, we need a little time enhancement here, but we have time for just a couple of quick questions, and then the speakers will be available also.
So I'm not asking you what the academy tells you to do. If I came into your office this afternoon and asked you for a prescription of Provigil because I want to stay up later tonight to get more work done, would you give it to me? So my choice or yours?
Well, it's a complex question, and I think the answer is the first thing I would do is treat that request as a chief complaint and begin to talk to you about why you want the medication and what your expectations of the medication are, how long you think you want to use the medication, and what would some of the rules be to stop that medication. At the end of the day, I don't think I prescribe the medication because I don't know enough about long-term effect. I don't know enough about efficacy. So that's where I come from. Now, the other thing I would also do, based on the history of physical exam, of course, is to make sure there's not an underlying problem here. You make the case that you want something to help you stay awake because you have a sleep disorder. Maybe you're not sleeping at night at all, you wake up and you're tired during the day. Maybe you have sleep apnea. Maybe you have something else that I can fix that has nothing to do with staying awake all night.
Thanks a lot to both of you for lovely presentations. I want to ask you about the access question. Donna just asked about whether you get permission, but I want to know who's going to pay for this. So suppose we take the kinds of cases where you're bringing people up to normal range, although they've been, you know, they sort of fall low on a statistical scale, say for smarts or happiness, whatever. And this can improve their opportunities in life, right? So they can get better jobs, make more friends, get laid more often, you know, whatever you want to speculate about. Should society pay for this?
love to. Because it really is bringing us into matters of fairness that I didn't select for this meeting. Usually, people are afraid of developing another two-class system where the wealthy, privileged get access to these drugs and leave the other side of the world behind them even more. But the notion you just brought on the table, that really society might have an obligation, or at least an interest, in compensating for the unfortunate natural lottery or social educated lottery that some people have come to suffer from, is very convincing. I mean, there are people like Brock and Daniels and Bickler who, from Chance to Choice, in their famous book, have really developed that idea of a duty to help people getting better by enhancement, increasing their chance of opportunities along the Rawlsian line, really, and not putting billions of dollars in quite ineffective psychosocial rehabilitation, but instead use the quick drug. This is really something we have to debate upon later in life of enhancers, but I'm sympathetic to the idea. Yeah.
But please join me in thanking Bettina Schöne-Seifert.